Hello, everyone. I'm Denise Tate from the University of Michigan, and I'm delighted to be invited by Jane Duff and Maeve Nolan to deliver this keynote presentation at the 9th ESPA European Conference. When Jane and I first spoke about this presentation was about 2 years ago before the pandemic. Things have changed drastically for all of us, especially for persons with spinal cord injuries. So my initial thoughts on this talk have changed as well. This is very timely, however, since my talk focuses on decision-making by persons with spinal cord injury during challenging times. Although I may have not had a lot of data on the effects of COVID to share with you today, the fundamental principles of how one prepares itself and decides on how to address the new complications and challenges in spinal cord injury remain essential, and even more now, since they are exacerbated by the limitations brought upon us by the pandemic. It is within this context that I'm very happy to speak to you today and present some of my work and my thoughts about this important topic in spinal cord injury, looking after the body and mind from a holistic perspective in research with implications from clinical care. But first, let me show you where I am located. The University of Michigan is the largest university in the state of Michigan and considered the Ivy of the Midwest. In the map, you can see on the left side, Ann Arbor, located in the southeast Michigan. And on your right side of the screen, you can see our network of hospitals in the medical campus. Let me introduce myself to you today as your speaker. I'm a psychologist by training with over 20 years of experience in working with persons with spinal cord injury at the University Hospital in its clinics. For the past 15 years, I have concentrated my work on my funded research and directed the University of Michigan Spinal Cord Injury Model Systems, a center for research excellence in spinal cord injury. More recently, my work has focused on secondary complications, especially issues of neurogenic bowel and bladder and their effects on quality of life outcomes. I wish to acknowledge my research sponsors and collaborators, and I have no conflict of interest to declare. The theme of this conference, as I said before, is spinal cord injury looking after the body and mind. This idea of unity was first discussed by philosophers and in philosophy by the works of Carl Jung, reflecting on the structure and the dynamics of the psyche. And I quote him here, "They are two sides of the same coin, and we cannot rid ourselves of the doubt that perhaps this whole separation of mind and body may finally prove to be merely a device of reason of conscious discrimination." Today, we will discuss challenges faced by persons with spinal cord injury and their holistic needs from a perspective of research, consumer-based, and clinician points of view. Tom Holtland will discuss his experience as a person with spinal cord injury and as a peer mentor working with those with spinal cord injury during COVID times. And Carrie Pilarski will address how to best intervene during these times. This is a new reality for all of us in spinal cord injury care. COVID-19 has had some devastating effects on a group of persons who already struggle with medical complications, access to transportation, access to medical care and caregivers, now facing yet another reality, the effects of this pandemic on their lives. Loneliness and social isolation were already special issues for this group of individuals. Because of needed precautions to avoid contamination, this is yet an unresolved problem. This issue, like in this photo here, which reflects a picture in Bangladesh, is especially challenging for those living in poorer areas of the world, like I said, India, Brazil, where mortality among the general population is so high that we have no figures for mortality among those with disabling conditions. Living with spinal cord injury requires extensive decision-making to address the many health-related issues and complications. People with spinal cord injury make daily decisions about their care that affect their physical and emotional well-being. These decisions are even more difficult when beyond regular complication one is dealing with life-threatening issues due to COVID. COVID affects a person with spinal cord injury differently, and especially a high-risk condition due to limited pulmonary function associated with spinal cord injury. Obtaining necessary care is yet another challenge, as hospitals and clinics are poorly staffed and overcrowded. In low-income countries, virtual visits are non-existent. Tom will address this issue during his interview later. And as we know, persons with spinal cord injury are more likely to present with other comorbidities such as cardiovascular disease, obesity, which will affect their ability to fully recover and survive. With all these factors to take into account, how does a person with spinal cord injury decide what is his or her best option to solve bladder and bowel dysfunction and complications alike? There are many challenges to making decisions during stressful times. My current research focuses on decision-making related to complications, and more specifically related to bladder and bowel dysfunction. On this slide, we see some of the factors to consider when attempting to understand the process of decision-making after spinal cord injury. People with spinal cord injury often take medications that affect their ability to think. Their cognition decreases with age and with comorbidities. Daily stresses about pain, bowel incontinence, access to resources such as transportation and caregiving are just other factors. And most importantly, social isolation and loneliness contribute to these difficulties as well. So here are some objectives of my talk. Keeping within the theme of body and mind, today I would like to discuss the many factors associated with decision-making to address bladder and bowel dysfunction. We'll examine the process of decision-making itself in association with outcomes, and we'll discuss some potential interventions to address and facilitate decision-making and directions for future research. We'll start by looking at what does research show in relation to making decisions during these challenging times. My own research focuses on decision-making in relation to surgeries that people have to make to address their neurogenic bladder and bowel. And imagine if these decisions have to be made in isolation during the pandemic. That's even more complicated. Here's the methodology for my study. We use a qualitative methodology, and we interview about 18 participants. We ask them about how they made decisions regarding their surgeries for bowel and bladder dysfunction, their roles in this decision-making process, and their level of satisfaction. We analyze our data with in vivo. The quantitative measures that we use as well to complement this qualitative inquiry were the PROMIS, the COMRADE, which is a decision-making tool, the Ways of Coping inventory, the Jung self-efficacy, the MOS social support, and the Psyche, which is a quality of life measure. The surgeries that we had included on our sample here included colostomies, ileostomies, suprapubic catheter insertions, urinary diversions, nephrectomies, and hemorrhoidectomies. Participants were on average 54 years old and about 27 years post-injury. 39% had complete paraplegia, 28% had complete tetraplegia, followed by 22% with incomplete tetraplegia and 11% with incomplete paraplegia. So let's look at our findings. Because of the limited sample size, not many results were significant, but some approach significant. Only findings that were significant or approach significance are being discussed here. This was a significant finding in spite of being a very small sample. And here what we found out is that those who underwent bowel surgery, such as colostomies, ileostomies, reported higher cognitive abilities as measured by the PROMIS versus those who underwent bladder surgeries. So we were wondering why. And I think one of the reasons we thought this had happened is because, at least in the United States, bowel complications are much less regulated, and the clinical practice are still quite general, and there is no specific practices for specific problems. It's very much an individualized approach to bowel problems. So it required the individual to use his or her cognitive abilities and problem-solving abilities in order to figure out what the best solutions were and how to decide about surgeries related to bowel. We also found that daily activity self-efficacy scores, as measured by the Murum, were higher for those who underwent bladder surgeries. And here again, it trended, the significance was not quite there, but it trended significantly. But it was higher for those who underwent bladder surgery, self-efficacy. And our thought here is that indeed for bladder surgery, the clinical practice guidelines are much more stronger. There's more evidence in the field, which tends to generate more self-confidence and self-efficacy in people undergoing these surgeries. Those who underwent bowel surgery had higher scores in planful problem-solving scores from the walk as a coping strategy. This goes along with the first finding that those who underwent bowel surgeries also use their cognitive abilities more than those who underwent bladder surgery. Here are some of the themes illustrating the main factors influencing decision-making for surgeries for bladder and bowel. First of all, the major factors were recurrent symptoms and complications and aggravations of those. The persistence of symptoms was really bothersome for people and really motivated them to make a decision. The second very important factor was doctor's communication style and establishing a trust on your doctor so that your decision-making process would be much clearer and much easier to make if you really trust your doctor and had clear communication with the doctor. This was followed by problems with current methods of management and proposed treatment versus the risk of surgery. There was no perfect treatment to be suggested here, so they had to do a balancing act of comparing the risk of surgery to the proposed treatments. We also saw an important factor being seeking social and emotional support, achieving independence and lifestyle changes, access to barriers and resources, and also seeking self-directed solutions such as online research, talking to experts, their doctors, their providers, and very special, talking to their peers and their families. We also looked at who made these decisions, who were the primary actors in making these decisions. And here we looked at the sample and divided them in terms of provider-led decisions, primarily made by the provider, primarily made by the participant, the person with spinal cord injury themselves, and a shared decision-making, where it was a 50-50% process to making a decision. Participants tended to initiate their own decisions with less complex surgeries, such as suprapubic catheter. Also, we found that with surgeries that were necessary because of consistent problems and aggravations where individuals had tried everything but nothing seemed to work, the individual himself or herself tended to lead the process of decision-making. With increased surgery complexity, decision-making enactment required greater doctor's involvement, such as in the ileoconduit and the ileostomies, for example, which were much more complex surgeries. So it was required that the individual would require more expertise from the provider in here. Here we found some trends in the data. Those who used shared decision-making had relatively higher self-efficacy scores. And Locatelli is one of the only people that actually describes shared decision-making in spinal cord injury as a specific competency for both patients and providers. She describes this as the process of matching patients' values and preferences with the goal of promoting autonomy. It's a decision talk method to explore options versus a more individualized approach. There were no associations between shared decision-making and psychosocial characteristics as measured by the psychosocial measures we had in this study, and partially because of the small sample size we had. So in terms of satisfaction with the surgery decisions, Most were satisfied with their surgery, especially bladder surgeries. 2 participants were very dissatisfied with the results of their bowel surgeries, and they attributed it to the lack of clear communication with their doctors about their expectations from surgery, as well as having no time to ponder on these decisions. So sometimes the emergency of having to make a decision very quickly was a major problem. Both colostomies and ileostomies received mixed reviews with dissatisfaction with respect to lack of informed choices and unexpected complication. This boils down again to the process of unity and to having a close relationship with your provider and clear understanding the consequences of your choices here. So in here I have a graph on the bottom here that shows you this unity. You have all these physical symptoms, the UTIs in terms of bladder sores, and then you have what is really required to make a good decision: trust and reliability on your doctor, emotional support from your peers and your family, in addition to knowing and doing your own research about how to make the best decision. Next, I share with you some of the words that our participants expressed when they were asked about how COVID has affected you in terms of your needs being addressed. What has happened? What has been the impact of this in your decision-making ability? So it's interesting to notice what people say here. As you said, as you can see here, it's really coming down to 2 levels. And one is very clearly expressed by this first individual here. Wait, you mean it could have been like this all along? So it's hard not to be a little bit bitter about that. So the fact that this is a normalcy, this is what people with disabilities go and endure all the time. This is not different. COVID is not different for us. Perhaps it's exacerbated, but the process is the same. We're always isolated, and it's always hard to get access to services. So this is not different. On the other side here, we have somebody else saying, so my wife couldn't even visit. This was an individual who actually had COVID and felt the impact of social isolation. My wife could not even visit me. None of my friends could visit me. So for 5 weeks, I didn't get to see anyone. I didn't even get to go out of my room. So definitely the impact of loneliness and social isolation was. Next, we see here some other responses for some people. Well, I've been like this for 49 years. I've been social distancing for 49 years. What's different? It's actually easier now if I can get into my social media and talk to others virtually. The other individual had expressed some concerns about having limited contact with others. So I'm not knowing exactly what's the normal here, not being able to compare. So this feeling of social connectedness or social connection being broken is an important one here that we should discuss or highlight. And the next one talked about due to COVID, we can now no longer let the public use these facilities. So the fact that individuals were restricted on their ability to use public restrooms, for example, where they couldn't have access to these facilities that they had in the past. Even if they could get away or they could go out someplace, the facilities were no longer available to them. And another individual saying, well, I'm a hermit anyway. I live in a farm, so this hasn't changed my life much. So a variety of responses, as you can see. In summary, here are some of the findings. We found that shared decision-making seemed to promote autonomy in decision-making. We also found that bowel surgeries were associated with mental alertness, possibly due to requiring individual problem-solving skills. Bladder with self-efficacy, and the bladder clinical practice guidelines in treatment evidence is stronger, promoting greater self-confidence in decision-making and self-efficacy. Recurrent symptoms and quality of the relationship with doctors were most influential factors in making surgery decisions. Most were satisfied with results, but relationships with doctors and trust was key. The impact of COVID on decision-making was mixed. Some felt nothing had changed, while others mentioned isolation and access to resources as problematic. Final thoughts? The influence of doctors and providers, particularly psychologists, in assisting patients with surgery decision is often minimized, and interventions geared to maximize trust and clear communications are very important indeed. So here's an important issue for body concerns, for example. You're having these symptoms over and over. How do we deal with that? Psychologists also can play a key role in addressing fears and concerns and educating patients about their effective ways of making decisions. They can educate providers on how to best relate to their patients and concerns. And these I here entitle these as the mind concerns. How do you help somebody to be at ease with the fact that they have to make these choices? And there's sometimes not the best choice. They are just choices you have to make. So some final recommendations for research. The importance of social connection in relation to decision making was highlighted during these interviews with persons with spinal cord injury. This is key for bladder and bowel dysfunction, which have major impact on quality of life. Better understanding social connection in relation to decision making seems important, as well as identifying those at risk for isolation and poor social connections. Healthcare systems should create opportunities for clinicians to partner with persons with spinal cord injury in developing better decision-making skills. Thank you very much for your attention today.